Okay, let's unpack this. Hyperbaric oxygen therapy, HbO2. It's a treatment with, well, proven effectiveness for certain conditions, right? Things like specific types of wounds that struggle to heal, or emergency situations like severe carbon monoxide poisoning.
Absolutely, those are the established ones.
But pushing the boundaries, exploring entirely new uses, and actually getting robust, clear-cut data on those emerging indications, that's where the real scientific and clinical challenge often lies in hyperbaric medicine.
You've hit the nail on the head. The very nature of hyperbaric medicine practice, while it often involves smaller individual treatment centers, you don't always have these massive multi-specialty hospitals with huge hyperbaric units.
Right. So the patient volume for any single less common condition getting HbO2 can be pretty limited at one place.
Exactly. And that inherent structure makes it incredibly difficult to, you know, assemble the large patient cohorts you need, or to coordinate the extensive multi-center randomized controlled trials that are really the gold standard for definitive evidence on new therapeutic applications.
Right. So what tends to happen then is that HbO2 gets explored, maybe used clinically sometimes,
Hmm. And certainly discussed within the community.
for conditions where that absolute yes, it definitely works, or no, it doesn't. It just hasn't been nailed down by that big trial data yet.
Precisely. There's this often extended period where treatment is being considered, maybe offered, based on a strong biological rationale,
Yeah.
maybe some promising early clinical observations,
Yeah.
but yeah, without that statistically powerful confirmation.
And that gray area, that active frontier of research and clinical experience, well, that's the heart of our deep dive today, the emerging indications for hyperbaric oxygen therapy.
It is. And for this exploration, we're drawing on a really comprehensive stack of sources. This includes, the extensive personal clinical experiences of the authors, who are real experts in the field.
People who've seen this stuff firsthand.
Definitely. Plus, insights presented and discussed at major scientific meetings focused on hyperbaric medicine. Also, invaluable data collected from the International Multicenter Registry for Hyperbaric Oxygen Treatment that captures real-world treatment patterns.
So what's actually happening out there?
Exactly. And finally, a broad systematic search across the big biomedical databases. Think PubMed, Scopus, the Cochrane Library, specifically looking at the past 6 years to capture the most recent research.
Okay, and just to make sure we're all on the same page right from the start, when we talk about emerging indications here, we're using the definition from the source material, right?
Yes, absolutely. It means conditions where there's, well, demonstrable biological plausibility, a solid physiological reason to hypothesize that HbO2 could actually have a beneficial effect.
Makes sense scientifically.
Right, and where there's at least some clinical evidence, ideally of reasonable quality, to sort of back that idea up in practice.
But, and this is the key part, these conditions haven't yet been formally reviewed and approved by the Undersea and Hyperbaric Medical Society.
That's the crucial qualifier. The Undersea and Hyperbaric Medical Society, or UHMS, is the key professional body in this field. They're the ones responsible for evaluating the evidence and setting the standards for clinical practice.
Okay, so we're not covering the conditions like, say, carbon monoxide poisoning, gas embolism, decompression sickness, or certain chronic wounds that already have that formal UHMS stamp of approval.
Nope, not today.
We're looking squarely at the areas where research is ongoing, clinical experience is building up, and the potential is being actively investigated. Based on the material we've reviewed, the specific emerging indications we'll be exploring in depth today. It's quite a list covering a broad spectrum.
It really is.
We've got inflammatory bowel disease that includes ulcerative colitis, Crohn's disease, pouchitis, and pyoderma gangrenosum, which is often linked to it. Then calciphylaxis, frostbite.
Both the acute phase of COVID-19 and the persistent symptoms, long COVID or post-acute COVID syndrome.
Right. Also acute acoustic trauma, Raynaud syndrome, and those really tough ulcers from systemic sclerosis.
Diabetes mellitus, but specifically beyond the established use for diabetic foot ulcers, and finally, traumatic brain injury, especially looking at the lingering effects of mild TBI.
And as you look through that list, you can see some potential overlap, right? Like pyoderma gangrenosum and calciphylaxis might come up when talking about difficult wounds generally.
Or frostbite clearly relates to traumatic ischemia or burns. But here, they're specifically highlighted as areas where HbO2 is being explored as an emerging therapeutic option, where that definitive evidence is still accumulating.
Got it. So our mission today is to really take a deep dive into each of these. We'll unpack the physiological rationale, why someone might think HBO2 would help in the first place.
Yeah, the how it works part.
Exactly. Examine the clinical evidence that's out there, detail the key findings from relevant studies, look at real-world data like that registry.
And discuss the clinical nuances, how it might actually be used.
All of this while keeping in mind that fundamental challenge we mentioned, gathering that definitive large-scale data in hyperbaric medicine. We're here to impartially present the information, not really to endorse anything outside its established role, but to give you, the listener, a comprehensive picture of what this landscape of emerging indications looks like right now.
All right, let's start by getting a clearer picture of this emerging indications landscape and the fundamental challenges involved in studying them. We touched on this, but really understanding the data limitations is crucial context for everything else.
Absolutely. That core difficulty in obtaining reliable, large-scale outcome data for many potential uses of hyperbaric oxygen therapy. It stems directly from the practical realities of the field. Unlike, say, treating a very common condition where you can run massive multi-center trials with thousands of patients, hyperbaric medicine centers are often, as we said, smaller units.
So the patient volume for any one specific condition, especially if it's rare or HBO2, isn't the first thing people try.
Okay.
It's naturally limited at each site. Exactly. So imagine a clinician at one of these centers. They see a patient maybe with severe tissue hypoxia or a non-healing wound, and based on how HBO2 works, they think, hey, this might help.
Makes sense. They might try it.
They might. And if it seems to help, maybe they document it. That experience often becomes the starting point.
Like a case report.
Exactly. The typical starting point for exploring a new potential use for HBO2 is often the publication of individual case reports or maybe small case series from just one center.
Yeah.
These provide that initial signal, right?
Mm-hmm.
They suggest there's biological plausibility, maybe some patients are seeing a benefit.
But that's just the beginning. To move from that preliminary stage, which just raises interesting hypotheses, to getting definitive data on efficacy, you need much bigger studies.
Much bigger. You need larger prospective trials, often requiring multiple centers to team up just to recruit enough patients to have real statistical power.
And coordinating all that.
Hmm.
The HBO2 protocols, making sure everyone's doing it the same way, managing patients and data across different sites. That sounds like a huge logistical challenge.
It truly is a complex undertaking, and the result is precisely what the source material describes. For many potential indications, you get this extended period, sometimes years, where hyperbaric oxygen is being used based on a good scientific hypothesis, maybe some positive signals from early reports.
But without that really robust, large-scale evidence needed to say conclusively, yes, it works, or no, it doesn't, across a broad population.
Exactly, and that dynamic means the evidence base for these emerging uses is often, well, less mature than for the established indications. Now, you detailed the sources used for this chapter earlier. Could you just quickly recap that blend of info?
Sure. So this specific section on emerging indications drew upon several key things. First, the author's own clinical experiences. These are seasoned practitioners. They've used HBO2 in these novel contexts.
Real-world perspective.
Right. Second, info gathered from relevant scientific meetings, often where the newest data and ideas first get aired out among peers.
The cutting edge.
Third, that really valuable data from the International Multi-Center Registry for Hyperbaric Oxygen Treatment. That registry prospectively collects data on all sorts of conditions being treated across multiple centers, gives you real-world insights, even for non-standard uses.
Capturing what's actually happening in practice, even outside formal trials.
Exactly. And fourth, it was grounded in that broad, systematic search of the major biomedical databases over the last 6 years, covering PubMed, Scopus, Cochrane Library.
And the search terms used there?
Specifically, hyperbaric oxygenation, hyperbaric therapy, and oxygen treatment. Then they used filters to zero in on clinical evidence, studies involving patients and outcomes. They looked through those results for relevance and novelty, focusing on published data for conditions showing emerging clinical evidence for HBO2.
So a really solid mix. Expert knowledge, conference buzz, real-world registry data, and a systematic literature review. And based on all that, the main conditions they picked out for detailed discussion were:
The primary emerging indications selected were inflammatory bowel disease covering ulcerative colitis, Crohn's, pouchitis, and related pyoderma gangrenosum. Then calciphylaxis, frostbite, diabetes beyond DFUs, acute and post-acute COVID-19, acute acoustic trauma, Raynaud's and systemic sclerosis ulcers, and traumatic brain injury.
And as you pointed out, some of these naturally cross over into other areas: pyoderma gangrenosum and calciphylaxis in problem wounds, frostbite in traumatic ischemia.
Right. They pop up elsewhere too, but here they're specifically flagged as active areas of emerging use and investigation for HBO2, where the evidence is still building towards that definitive status.
Okay, let's refine that definition of emerging indications just a bit more.
Yeah.
We said biological plausibility plus some high-quality clinical evidence, but not yet UHMS approved.
Yes, that's the core. An emerging indication is a condition where you have a strong scientific rationale based on how HBO2 works, a reason to think it should help, and where initial clinical data, maybe case series, observational studies, or smaller controlled trials, gives some support for that idea and meets a certain quality bar.
But crucially, it hasn't gone through that formal review and approval process by the Undersea and Hyperbaric Medical Society's Hyperbaric Medicine Committee.
And it's important to remember, as you mentioned, that getting formally approved doesn't always require those huge multi-center randomized controlled trials, does it?
That's a really crucial point the source makes. The path to UHMS approval doesn't always demand being backed only by large, high-quality RCTs. Think about conditions that are sporadic, maybe rare, but have catastrophic consequences, like necrotizing fasciitis.
That flesh-eating bacteria thing.
Right, that rapidly progressing, life-threatening soft tissue infection. The clinical need there is so urgent, and the results seen in case series or smaller studies can sometimes be so compelling that it can provide enough evidence for approval, especially when the alternative treatments are limited or have worse outcomes.
Okay, so the evidence part isn't one size fits all. It can adapt based on the disease, its severity, and what else is available.
Exactly. And there's a key evidentiary filter the UHMS Hyperbaric Medicine Committee uses. They explicitly compare the level and quality of evidence supporting HBO2 for a potential indication with the existing evidence that supports the standard and alternative treatments already commonly used for that same condition.
Ah, so it's relative, not just is the HBO2 evidence perfect, but how does it stack up against what clinicians are already doing and what's the proof behind those practices?
Precisely. And this working principle has a significant implication. For many of these conditions where HBO2 is being explored as an emerging indication, the quality of the evidence supporting its use is actually at least as high as, maybe even higher than, the evidence supporting the commonly used alternatives for that condition.
Really? Even for things considered standard care?
Often, yes. And often, these alternative treatments are routinely reimbursed, considered standard, sometimes without ever having faced the kind of large RCPs people assume are required for everything.
That's a really interesting point. It reframes the evidence discussion. While the HBO2 evidence might not be a huge phase 3 trial, its standing relative to other common practices might be quite strong. Okay, quick recap here. Emerging means plausible science plus some decent clinical data, but not UHMS approved yet. Approval doesn't always need massive trials, especially for rare bad stuff, and the evidence is weighed against what's already standard care, which itself might not always have top-tier evidence.
That's a solid summary of the definition and the evidence context.
Now, to really visualize just how diverse this emerging landscape is, the sources look at data from that international registry. You mentioned a figure 1.
Yes, Figure 1 gives a very clear snapshot. It pulls data from 26 centers participating in the International Registry for Hyperbaric Oxygen Treatment. And crucially, it focuses specifically on times HBO2 was used for conditions other than the currently UHMS-approved ones.
So what does it actually show? What kind of picture does it paint?
It's essentially a graphic, often like a bar chart. On one axis, you have this long list of specific clinical conditions. On the other axis, you see the number of treatment courses given for each of those conditions across all the centers reporting to the registry. It really represents that real-world clinical activity and, frankly, curiosity about where HBO2 might help.
Looking at the list of conditions shown or mentioned with Figure 1, wow, it really highlights the breadth. We see things like ulcerative colitis, pyoderma gangrenosum, calciphylaxis, frostbite, post-COVID syndrome, osteonecrosis or vascular necrosis, pterygium, head trauma, infected implanted hardware, pneumatosis intestinalis, ischemic bowel.
Keep going. Malignant otitis externa, non-arteritic anterior ischemic optic neuropathy, acute COVID-19, retinal vein occlusion, Raynaud syndrome, femoral head necrosis, invasive fungal infection, chronic anal fissure, vasculitic ulcer, BK virus cystitis, irradiated vessels, graft versus host disease, decubitus ulcer, greater trochanteric pain syndrome.
Rectovaginal fistula, argon poisoning, pouchitis, chemotherapy-related bladder ulcer, post-surgery in irradiated tissue. recurrent perianal abscess, tendon, ligament, or cartilage injury, traumatic brain injury, axonotmesis, non-healing bowel anastomosis, and even multiple sclerosis. And then, like you always see in these registries, there's a big chunk just labeled other.
Yes, and even within that other category, the numbers aren't small counts, like 15, 34, 40, 10 cases are listed for various unspecified conditions. It just further underscores the huge range of potential applications being explored. While the exact counts for each condition might change depending on the registry report, the main message from this figure is the sheer variety and diversity of problems where HbO2 is being used in practice, even before formal approval.
It's truly staggering. Inflammatory, vascular, infectious, traumatic, neurological, it covers so much ground.
Exactly. And the primary interpretation of Figure 1, as the source points out, is that this diversity really underscores the ongoing exploration of HbO2's potential across a wide landscape. It also reinforces that critical need for more dedicated studies, rigorous clinical trials to properly evaluate the effectiveness and define the role of HbO2 in each of these many areas.
So the registry data gives us that bird's eye view of the immense scope of clinical interest and real-world use in these emerging areas. It really shows the scale of this emerging landscape.
It's definitely a dynamic and evolving space in hyperbaric medicine.
All right, let's start drilling down into some of these selected emerging indications, beginning with inflammatory bowel disease. This seems like a significant area of investigation.
It absolutely is. Inflammatory bowel disease, IBD, is a key focus area. IBD itself is a group of chronic inflammatory disorders of the digestive tract, mainly ulcerative colitis and Crohn's disease. We also include Burkitis here, that's inflammation in the pouch made after colectomy for UC, and pyoderma gangrenosum, an inflammatory skin issue often associated with IBD, which can be really tough in these patients.
Okay, so within that IBD umbrella, what specific clinical situations are we looking at for HbO2?
Based on the source material, the main scenarios include acute flares of ulcerative colitis, especially in patients who are resistant to standard medical therapies or maybe can't receive them for some reason.
Like when the usual drugs aren't working or aren't an option.
It's also being explored for fistulizing perineal Crohn's disease, those difficult-to-treat abnormal connections around the anus, particularly when they're refractory to other treatments. Also, pouchitis that isn't responding to standard antibiotics or other therapies, and refractory pyoderma gangrenosum, especially when linked to IBD. And although the focus is often on these tough cases, HbO2 has also been used for Crohn's disease affecting the bowel lumen itself.
And what's the general consensus from the literature reviews on HbO2 and IBD?
Several recent reviews looking at the available studies generally conclude that, yeah, hyperbaric oxygen therapy could indeed be a useful adjunctive or perhaps alternative treatment option for IBD in these challenging situations.
Let's dive into the specifics then, starting with acute ulcerative colitis flares. What's the goal there, and what do the key studies show?
The main goals of using HbO2 in acute UC flares are pretty significant. You want to induce clinical remission, ideally avoid the need for colectomy, removing the colon as a major surgery, and prevent or delay needing to escalate to more aggressive second-line therapies like biologics or immunosuppressants.
And the source mentions a small, sham-controlled, randomized trial for this. Even if small, that kind of study carries weight.
It does. This study looked at patients hospitalized with moderately severe UC flares. They were randomized. 10 patients got active HbO2 at 2.4 atmospheres absolute, and 8 got a sham control treatment. Importantly, HbO2 was used adjunctively added onto standard treatment, which usually meant IV steroids in this setting.
So, added to the usual care, what did they find?
The authors concluded that adding HbO2 led to significantly higher rates of clinical remission compared to the sham group.
Higher remission rates in acute hospitalized flares. That's very clinically meaningful.
It is. And critically, they also saw a statistically significant reduction in how often patients needed to progress to second-line therapy during that hospital stay. This suggests HbO2 might help patients respond enough to avoid needing those stronger, often more complex treatments right away.
Was there any follow-up work on how best to use it, like dosing?
Yes. A subsequent Phase 2b trial looked specifically at different dosing strategies for acute UC flares. That trial found that giving 5 treatments with HbO2 was statistically better than giving only 3 treatments for achieving the desired outcomes. That gives us some valuable early info on protocol design.
So for acute UC flares, encouraging preliminary sham-controlled evidence suggests HbO2 might help induce remission, maybe avoid escalating therapy or even surgery, and 5 treatments looked better than 3 in one study.
That's a good summary of those specific findings.
What about refractory fistulizing Crohn's disease? That's notoriously difficult to manage.
It is indeed a particularly challenging form of Crohn's. The goal when adding HBO2 for refractory fistulizing perineal Crohn's is to significantly reduce disease activity, decrease the drainage from the fistulas, which causes pain and infection risk, and ideally induce clinical remission, or at least a major response.
And the source highlights a prospective trial by Lansdorp and colleagues on this.
Yes, this was a prospective study. They enrolled 20 consecutive patients with refractory fistulizing Crohn's. These patients got a course of 40 HBO2 sessions. They tracked outcomes using objective measures like the perianal disease activity index score, plus radiology and biochemical markers.
40 treatments. What did they see afterwards in this tough group?
The results were quite positive. 13 out of 20 patients, that's 65%, had perianal disease activity index scores below 4 after treatment. A score under 4 basically means inactive perianal disease. Plus, 4 patients, 20%, achieved complete clinical remission, and a total of 12 patients, 60%, had a significant clinical response.
So a big majority saw meaningful improvement or even remission of their perianal disease.
Yes, overall, the study showed significant clinical, radiological, and biochemical improvement. And importantly, the source notes this improvement wasn't just temporary. The benefit was maintained at 1 year of follow-up, suggesting a more lasting effect.
Maintaining improvement for a year in refractory fistulizing Crohn's. That's pretty significant, as recurrence is so common.
It definitely highlights the potential impact of HBO2 in this specific, difficult patient group.
Okay, shifting to pouchitis. Inflammation of the surgical pouch after colectomy, you said. What's the evidence here?
Pouchitis is a relatively common issue after the ileal pouch anal anastomosis surgery, often done for severe UC. It's inflammation of that ileal reservoir or pouch. The source mentions initial evidence comes from 2 published case series and a case report, which all showed symptom relief and decreased disease activity with HBO2. One specific study highlighted is a single-center retrospective review.
What did that review of 46 patients treated for pouchitis find?
These patients got about 30 HBO2 sessions at pressures from 2.4 to 3.0 ATA. Outcomes were measured using the Modified Pouch Disease Activity Index, or MPDAI. They found a notable improvement. The mean MPCAI score dropped significantly from 9.8 before HBO2 down to 5.4 after therapy.
That's a big drop in the overall disease activity score.
It is. And looking deeper, the endoscopic MPDAI subscore that's based on how the tissue looks during endoscopy improved in all 3 key areas of the pouch: the afferent limb, the pouch body, and the cuff. Impressively, 13 out of 46 patients, nearly 32%, achieved complete endoscopic remission across all 3 pouch segments.
Complete endoscopic remission in almost a third. That's a strong signal for a condition often hard to manage.
It suggests HBO2 can have a direct positive effect on the inflammation in the pouch tissue itself, not just symptoms.
In pyoderma gangrenosum, the skin condition often linked to IBD. How does HBO2 fare with those wounds?
Pyoderma gangrenosum involves those painful, rapidly growing ulcers. It's an inflammatory thing, not infectious despite the name. The source indicates HBO2 has been shown to reduce wound size and promote healing in these lesions, based on both case studies and case series.
Does it work even in the really tough cases?
Yes. The source specifically highlights success even in challenging refractory cases. In those, HBO2 led not just to smaller wounds, but also better granulation tissue formation in the ulcer base and significantly less pain. There's even one specific case mentioned, peristomal PG, randostoma, notoriously hard to treat, completely resolved with full repithalization after only 4 days of HBO2 treatment.
4 days for complete healing in refractory peristomal PG. That's incredibly fast for a wound like that.
It really illustrates the potential for dramatic improvement in certain highly inflammatory, non-healing wound types.
We heard the International Registry is collecting prospective data on these IBD conditions too. What are those registry results showing so far?
The registry is indeed valuable for real-world outcomes. To date, for Crohn's disease, the registry results show statistically significant improvements in patient-reported quality of life, P0.001 and in 20. Also, in 16 patients with fistulizing Crohn's, a statistically significant reduction in fistula drainage, P0.01.
So better quality of life and less drainage. What about UC?
For ulcerative colitis, the registry data also show improved quality of life, P0.002, in 16 patients, and a statistically significant improvement in a composite bowel symptom score, things like frequency, pain, blood, urgency, P0.008, in a group of 11 patients.
So the registry data from multiple centers seems to line up with and support the findings from the smaller studies and series showing improvements in objective things like drainage and appearance, plus patient-reported outcomes like quality of life and symptoms.
It provides further supportive evidence from a broader collection of clinical experiences, definitely reinforcing those signals.
Now let's think about strategy. How does HBO2 fit into the overall IBD treatment picture? Is it usually used alone?
Typically, no. In the context of IBD, hyperbaric oxygen therapy is most commonly used as an adjunctive therapy. That means it's used alongside other standard medical treatments,
Yes.
steroids, immunomodulators, biologics like anti-TNF therapies,
So part of a combination approach.
usually. However, the source does mention a significant case study where HBO2 was successfully used as monotherapy, the only treatment for an acute UC flare in someone who had severe contraindications to most standard meds. So it shows potential as a standalone option in very specific, limited situations.
That highlights its potential when standard options are off the table.
Exactly. The source points out HBO2 can be particularly useful when a patient can't get standard first or second line treatments due to allergies, antibodies against a biologic, active infections like shingles that rule out immunosuppression, or other medical reasons.
Or maybe when there's a delay in starting those standard therapies.
Yes, that's another key scenario highlighted as really relevant. One of the most common and valuable uses of HBO2 in IBD, based on clinical experience, is for patients admitted to hospital with an acute severe ulcerative colitis flare. Often, these are patients whose flares are so bad they're at significant risk for needing a colectomy if things don't improve fast.
Because the inflammation is just too severe and not responding quickly enough?
Right. Or they might be patients who can't get high-dose steroids, or there's a delay in starting biologics. Crucially, HBO2 can serve as a bridge therapy in these situations.
A bridge, like bridging a gap in time.
Precisely. It's used to bridge that period between starting IV steroids, often the first step, and when biologic agents like infliximab or vedolizumab are started and actually have time to kick in. Biologics often take days, sometimes weeks, to show their full effect. HBO2 can potentially provide significant anti-inflammatory and healing benefits during that critical initial phase, maybe calming the flare enough to prevent surgery while waiting for the biologic to work.
I see, that makes a lot of sense. Patient comes in really sick, start steroids, plan for a biologic that takes a week or two to work, use HBO2 intensively in that waiting period to help stabilize them, potentially tip the balance away from emergency surgery.
That's an excellent picture of the clinical timeline and where HBO2 is often strategically used as that bridging therapy in acute severe flares.
Okay, let's consolidate everything we've covered on inflammatory bowel disease and related conditions. A mega recap for IBD.
Okay, summarizing the IBD section, we've seen several potential applications for HBO2 being explored. Treating acute UC flares, especially to avoid colectomy or bridge therapy, managing persistent refractory fistulizing Crohn's, addressing unresponsive pouchitis, treating refractory pyoderma gangrenosum linked to IBD, and maybe even luminal Crohn's.
The evidence is a mix, right? Case reports, series, some smaller RCTs specifically for UC flares showing benefits like increased remission, reduced escalation, plus supportive registry data on quality of life, symptoms, and objective measures like drainage.
That's right, evidence is still accumulating, but signals are encouraging for specific, often tough, scenarios in IBD. We also noted HBO2 is mainly adjunctive, used with standard treatments, but could be monotherapy if needed. Its value really shines when standard options are limited, delayed, or when a bridge is needed in acute flares. More data collection is ongoing.
Moving on to calciphylaxis. This is much rarer, but incredibly severe and challenging.
It is a rare, yet particularly devastating condition. You get progressive calcification of small blood vessels in skin and fat. This leads to profound ischemia, resulting in excruciatingly painful skin lesions and chronic, non-healing ulcers, often seen in patients with end-stage renal disease, especially on dialysis.
And because it's so rare, conducting large studies on any treatment must be difficult.
Exactly. The source highlights this critical point. There are very few large, well-designed trials for any treatment for calciphylaxis. This means even commonly used therapies like IV sodium thiosulfate could technically be considered investigational because large definitive RCTs just aren't there.
So the data challenge isn't unique to HBO2 for calciphylaxis. It's a field-wide issue for this rare disease.
Precisely. Clinicians are often relying on smaller series, observational data, and physiological rationale. However, HBO2 offers a particularly strong physiological rationale here.
Why does HBO2 make physiological sense for calciphylaxis?
Calciphylaxis causes severe damage to small blood vessels. This severely compromises blood flow, leading directly to profound tissue hypoxia, a severe lack of oxygen in those areas. This persistent hypoxia causes intense pain and is why these wounds are so resistant to healing.
Okay, damaged pipes, no oxygen getting through.
Right. Hyperbaric oxygen therapy works by dissolving significantly more oxygen directly into the blood plasma, bypassing the need for hemoglobin and red cells to some extent. This allows much more oxygen to reach these hypoxic tissues, even where blood flow is severely compromised. This enhanced oxygenation can help restore cellular function needed for healing, like collagen synthesis, and stimulate angiogenesis, the growth of new blood vessels, trying to restore circulation over time.
So by flooding the system with available oxygen, it gets past the blocked delivery system and tackles the core hypoxia problem.
That's the fundamental argument. Now let's look at the clinical evidence mentioned. A notable retrospective study is highlighted.
Yes, from the Alfred Hospital in Melbourne by Anne and colleagues, 34 patients with calciphylaxis got a full course of HBO2. What did they find in this tough group?
This study showed encouraging results, considering the poor prognosis. They found 58% of the patients showed significant clinical improvement in their lesions. And importantly, 32% achieved complete healing of their severe, non-healing wounds. The source also notes this paper reviewed previous, smaller studies, consolidating earlier experience.
Improvement in over half, complete healing in nearly a third, for wounds often considered intractable. That's significant for calciphylaxis.
It is, and it's the strongest clinical signal to date. Furthermore, the source refers to a comprehensive review by Nigwekar et al. In a major National Kidney Foundation journal.
And what was their conclusion regarding HBO2?
They explicitly noted the lack of high-level RCT data for any calciphylaxis intervention. However, based on the available evidence, including studies like N et al.'s, they made a clinical recommendation. They recommended HBO2 as a second-line therapy for recalcitrant calciphylaxis wounds, meaning those severe ulcers that haven't responded to initial standard management.
So a prominent expert review, acknowledging the data limitations for all treatments, still felt the evidence for HBO2 was enough to recommend it for the toughest cases.
Correct. It's a pragmatic assessment based on clinical need, plausible mechanism, and the promising results seen, relative to evidence for other practices.
Okay, let's do a mega recap for calciphylaxis.
In summary, calciphylaxis.
Weir.
Rare, severe, hard to study any treatment. Strong physiological rationale for HBO2 tackling hypoxia, promoting healing, maybe angiogenesis. Promising retrospective data shows improvement in over half, complete healing in nearly a third. Given the overall lack of strong trial data for any intervention, expert reviews recommend HBO2 as a second-line option for recalcitrant wounds, highlighting its potential value when other options fail.
All right, let's move on to frostbite. This feels like one that makes immediate intuitive sense given what it does to circulation.
It does. The physiological rationale for HBO2 in frostbite is quite direct. Freezing injury disrupts circulation, leading to significant ischemia, lack of blood supply, and tissue hypoxia. Hyperbaric oxygen directly counters this by boosting oxygen delivered to that compromised tissue, even with reduced blood flow.
And maybe helps with secondary damage, too.
Yes, that's part of it. Besides just getting oxygen in, HBO2 is thought to help mitigate ischemia reperfusion injury, that damage that happens not just during the lack of blood flow, but when circulation returns to the injured area. Restoring flow can paradoxically cause more damage from inflammation and free radicals.
Right, thawing out isn't always gentle. What's the clinical evidence here?
The source highlights a key study from Switzerland, published in 2021 by Magnan and colleagues. They prospectively recruited 28 patients with severe frostbite. These patients got combination therapy. HBO2 plus iloprost, a common drug to improve blood flow in frostbite. Their outcomes were compared to a historical control group of 30 patients treated with iloprost alone.
So, iloprost plus HBO2 versus iloprost alone using historical controls. What was the main outcome and what did they find?
The critical outcome was the rate of amputation. The study found patients getting adjunctive HBO2 had significantly fewer amputated segments compared to the controls getting iloprost alone. The reported odds ratio was 45, with a wide confidence interval of 6 to 335.
An odds ratio of 45, that's huge. What does that mean practically for a patient?
It suggests a dramatically lower chance of needing amputation in the HBO2 group. An odds ratio of 45 means the odds of needing amputation were estimated to be 45 times lower with HBO2 added. While the confidence interval is wide, reflecting sample size, the sheer magnitude of the effect points towards a potentially massive reduction in limb loss risk.
Wow, potentially limb-saving implications. What was the HBO2 protocol in that study?
In the Magnan study, patients got HBO2 at 2.5 atmospheres absolute for 150 minutes per session, one treatment per day for 7 days.
Okay, specific, relatively short course. Is there other literature supporting HBO2 in frostbite?
Yes, the source mentions other literature summarized in a review by Kemper et al. includes case reports and smaller series where HBO2 was used adjunctively with other standard treatments like prostaglandins or anticoagulants, showing positive outcomes in some cases.
So the Swiss study provides stronger evidence, but there's a history suggesting potential. Let's elaborate a bit more on those possible mechanisms.
Certainly. Beyond the main effect of boosting oxygenation in injured tissue, other potential benefits in frostbite include inducing peripheral vasodilation. Studies show HBO2 exposure can lead to blood vessel widening after treatment sessions, potentially improving blood flow over time. And, as discussed, it's hypothesized to mitigate ischemia-reperfusion injury by dampening inflammation and reducing oxidative stress when blood flow returns to damaged tissues.
So not just oxygen delivery, but influencing blood vessel function and the body's response to the injury itself.
That's the proposed multi-pronged mechanism. These effects working together could help preserve tissue viability, reduce irreversible damage, and ultimately lower the need for amputation.
Mega recap for frostbite.
For frostbite, strong physiological rationale counteracting ischemia-hypoxia from freezing, potentially mitigating reperfusion injury. Key clinical evidence. The prospective Swiss study showing significant reduction in amputation risk with adjunctive HBO2 plus iloprost. Proposed mechanisms, enhanced oxygenation, post-treatment vasodilation, and mitigating ischemia-reperfusion injury, all aiming to preserve tissue and reduce limb loss.
Let's turn our attention now to a very prominent recent area of interest for HBO2, both acute COVID-19 and the persistent symptoms known as post-acute COVID syndrome or long COVID.
These conditions certainly brought HBO2 into the spotlight during the pandemic. It was advocated for use in two distinct scenarios. First, treating the acute severe hypoxia in patients with significant lung involvement from COVID-19.
The breathing problem.
Right. And second, addressing that array of persistent symptoms some people experience long after the acute infection has gone long COVID.
Let's start with acute COVID-19. What's the underlying disease process that gives a rationale for considering HBO2?
The initial event is SARS-CoV-2 infection. But the most severe consequence, especially early on, was acute respiratory distress syndrome, ARDS.
And ARDS means severe oxygenation problems.
Yes, extreme hypoxia, usually defined by a very low PaToB to ICIO2 ratio below 300. And you see those characteristic bilateral lung changes on imaging diffuse ground glass opacities, showing inflammation and fluid in the air sacs.
Widespread lung damage blocking oxygen transfer.
Exactly. And the cause is believed to be an uncontrolled inflammatory response against the virus. If that systemic inflammation isn't contained, it can spread beyond the lungs, affecting multiple organs, leading to multi-organ failure and, sadly, high mortality.
But it wasn't just the lungs and severe COVID, right? There was a vascular issue, too.
And that vascular pathology is critical for understanding HBO2's potential role. SARS-CoV-2 also causes widespread inflammatory injury to the endothelial lining of blood vessels everywhere. This promotes a procoagulant state, makes blood clot more easily, and leads to both macro and microvascular thrombosis, clots in big and small vessels. This vascular damage is thought to contribute significantly to multi-organ dysfunction affecting kidneys, heart, brain, etc.
So lung damage causing the primary oxygen issue, plus systemic vascular damage causing clotting and impaired blood flow everywhere, leading to more organ damage. How might HBO2 tackle this complex mess?
Researchers like Perdrizet and Feldmeyer, cited in the source, explored this. HBO2 has known anti-inflammatory effects, potentially dampening that runaway immune response. It also has antithrombotic effects, possibly counteracting the clotting tendency. These properties, on top of its powerful ability to deliver high oxygen levels, could theoretically lessen disease severity, improve oxygenation, and reduce multi-organ damage.
Let's look at the clinical context during the acute phase, especially early in the pandemic.
Early on, a significant chunk of hospitalized COVID patients, maybe 15–20%, developed hypoxic respiratory failure, needing advanced non-invasive ventilation, or even intubation and mechanical ventilation. And mortality on mechanical ventilation was tragically high.
And this is where HBO2 was proposed as a way to potentially avoid ventilation.
Exactly. Given its ability to boost oxygen delivery, HBO2 was proposed as an extended non-invasive technique to treat acute hypoxia, aiming to avoid mechanical ventilation and its high risks. Beyond just oxygen, the proposed benefits included those anti-inflammatory effects, maybe even a direct virucidal impact, potentially altering the long-term course.
Were there early clinical results supporting this?
Yes, some early retrospective results from various centers did tend to support these ideas, suggesting improved oxygenation and clinical status. Based on this initial limited evidence and the strong rationale, in April 2020, the Undersea and Hyperbaric Medical Society issued a position statement.
What was their official stance, though?
They concluded that While there wasn't enough high-level evidence yet for routine use outside an IRB-approved trial, the physiological rationale for using it in severe hypoxia made sense.
Acknowledging potential, endorsing research, but cautioning against widespread, unproven use? Were there specific early studies mentioned?
Yes, for instance, a series from Russia by Levina et al. Reported on 32 patients with moderate to severe respiratory issues. They used lower pressures, 1.4, 1.6 ATA, for up to 60 minutes. Overall, these patients seemed to do better than controls, with increased SpO2 and less shortness in breath.
And any early direct comparisons beyond just case series?
Yes, the Gorenstein et al. Study provided some early direct comparative data, though observational. They compared 20 COVID patients, CU2 93% on air, needing 215 lemon oxygen, who got HbO2, with 60 propensity-matched controls who got standard care without HbO2.
Propensity match to try and make the groups comparable.
Exactly, to reduce confounding. Looking at outcomes, in the 20 HbO2 patients, only 10% were intubated and died. The other 18 were discharged by study end. In the 60 controls, 30% were intubated, 22% overall died, and 5% overall remained hospitalized.
A noticeable difference in intubation and death in that comparison.
Yes, the calculated hazard ratio for inpatient mortality for HbO2 was 0.37, about a third of the risk, though not statistically significant, PO 0.14, likely due to size. But the hazard ratio for needing mechanical ventilation was 0.26, about a quarter of the risk, and this was statistically significant, PO 2.05.
A hazard ratio of 0.26 for ventilation is a strong signal that HbO2 might significantly reduce that risk.
It is. The authors concluded HbO2 seems safe, and their findings strongly supported the need for a well-designed multi-center RCT to confirm these potential benefits.
Were there studies looking beyond clinical outcomes at biochemical markers of inflammation or clotting?
Yes. Keller et al. Did an observational cohort study comparing standard treatment plus HbO2. They found HbO2 patients reached baseline SaO2 90% faster. More importantly, they found significant differences in biochemical markers.
What specific markers were affected?
Reduced levels of D-dimer in the HbO2 group. That's a marker for clots and inflammation, often high in severe COVID. They also found increased levels of certain cytokines, the anti-inflammatory IL-1RA, and the pro-angiogenic VEGF, which promotes new blood vessel formation.
So, reduced markers of bad stuff, clotting inflammation, and increased markers of good stuff, anti-inflammation, vascular repair.
Exactly. Keller's group concluded HbO2 reduced pro-inflammatory agents and increased anti-inflammatory and pro-angiogenic markers. This provided biological plausibility supporting the clinical trends, suggesting HbO2 wasn't just adding oxygen, but actively influencing the disease process.
So, rationale, early observations, biomarker studies, all pointing towards potential benefits in acute COVID. What happened when the first randomized controlled trials came out in 2022?
The first two RCTs comparing HbO2 with standard care were published in 2022. The source notes that while both reported positive results, they ultimately fell short of clearly quantifying the clinical benefit with the definitive statistical certainty you want from an RCT.
Why was that? What were the designs and results?
Let's take Canelato et al. First.
Yes.
They randomized 40 patients. 20 got standard care, supportive respiratory therapy, antibiotics, dexamethasone. 20 got standard care plus daily HbO2, 90 minutes at 1.45 ATA, mean of 6 treatments.
And the main outcome measured?
Time to achieve baseline SpO2 of 93% plus on room air. The HbO2 group hit this in a median of 3 days, IQR 1.04.5. The control group took significantly longer, median of 9 days, IQR 5.5, 12.5. That difference was statistically significant, P 0.01.
So HbO2 patients oxygenated better, much faster.
That was the key finding. They also tracked poor outcomes, intubation or death, only 4 total. 1 in the HbO2 group versus 3 in the control group. Not statistically significant in this small sample. Importantly, they stopped recruitment early based on an interim analysis showing that SpO2 benefit.
Stopping early means they weren't fully powered for less frequent outcomes like intubation or death, even if a trend was there.
Exactly. The second RCT, by Weir et al., randomized 28 patients, but unfortunately had to terminate early due to poor recruitment. Despite that, they still saw a strong trend towards benefit. No deaths in the HbO2 group versus 3 deaths in the standard therapy group, P of 0.06, again likely hampered by small numbers.
Why was recruitment hard for that trial?
The authors noted recruitment dropped off as the pandemic changed. Public health measures, vaccinations. Fewer patients presented with a specific level of respiratory insufficiency needed for their study. The changing pandemic landscape directly hit their ability to finish the trial.
Really highlights the challenge of research during a public health crisis. Were there larger, multi-center RCTs that also ran into trouble?
Yes, Huang et al. Recently presented data from what was meant to be a large multi-center RCT. It compared HBO2 versus standard care for acute COVID patients needing 6L-min oxygen but not yet ventilated.
What were the results from that study's intention to treat analysis?
Looking at primary outcomes, deaths were 111, 9% in HBO2 versus 116, 6% in standard care, P1.00. Progression to ventilation was 311, 27% in HBO2 versus 116, 6% in standard care, P0.27. Neither difference was statistically significant.
So this larger effort also didn't show a statistically significant benefit on those key outcomes?
Correct. And like the Weir study, this trial also closed early. Planned for 180 patients per arm, but closed due to fewer suitable patients. The authors concluded viral mutations, changing transmission-altered clinical presentation, reducing eligible patients. They also cited logistical challenges with chambers and suggested new therapies and variants might explain differences between their results and earlier promising evidence.
So initial signals looked good, rationale was strong, some smaller studies positive. But the larger rigorous RCT struggled with recruitment due to the evolving pandemic, making it hard to get enough power to definitively prove benefits on mortality or ventilation.
That seems to be the complex picture. The source also notes systematic reviews summarizing this initial modest clinical evidence have been published.
And the overall takeaway from those reviews.
Generally, they conclude HBO2 appears safe and effective for oxygenation in COVID patients. However, they consistently note limited evidence on the full range of clinical effects and specific mechanisms. They all call for more extensive, well-designed studies. The source points out the experience gained successes and challenges will be relevant for future respiratory viral infections, emphasizing the need for new studies.
Okay, let's shift gears now to post-acute COVID syndrome, or long COVID. Very different presentation than acute respiratory failure.
It is. Long COVID describes that complex mix of diverse symptoms persisting for weeks, months, or longer after the initial infection clears, regardless of ongoing active virus.
How common is it?
It might be quite common. One estimate cited suggested 10–20% of infected individuals might develop long-term impairment, though the source notes incidence might be declining with newer strains and vaccination.
And the symptoms patients report.
Very diverse, affecting multiple systems. Based on the source, some of the most frequent are debilitating fatigue, around 58%, headache, 44%, cognitive impairment or brain fog, 27%, and persistent shortness of breath, 24%.
Those are just the top ones. And the source mentions a possible similarity to chronic fatigue syndrome.
Yes, some authors pointed out extensive similarities in symptom profiles. However, the source is careful to say the significance of any link remains speculative and needs more investigation.
And the proposed mechanism for why these symptoms persist? Still unclear.
The exact mechanism remains unclear, a major challenge for finding treatments. One leading hypothesis is a persistent, low-grade procoagulant state, subtle ongoing clotting tendency, combined with an uncontrolled ongoing inflammatory response, even without active virus. Both could potentially result in chronic subtle tissue hypoxia, especially in the brain and other organs.
So not the dramatic acute hypoxia, but a chronic low-level oxygen deprivation from lingering inflammation and microclotting, affecting multiple tissues, especially the brain.
That's a leading hypothesis, providing a rationale for exploring therapies like HBO2, given its effects on oxygenation, inflammation, and clotting.
What was the first formal report on using HBO2 specifically for long COVID?
The first mentioned was a retrospective case series from England. 10 patients treated for persistent post-COVID symptoms. They got 10 sessions of HBO2 at 2.4 ATA for 45 minutes.
What did that small retrospective series find, pre versus post-treatment?
Several statistically significant improvements. Most notably, fatigue scores improved significantly, p-able is 0.006, with a very large effect size, Cohen's d 1.75. Remember, 0.8 is large, so 1.75 is substantial. Also significant improvements in global cognition, p-able 0.01, large effect size d 1.07, and executive function, p-o 0.004, large effect size d 1.06. Very large and large effect sizes for fatigue and brain fog improvement in a small series. That's striking. Generated interest, I imagine. It was a powerful signal, especially with few effective long COVID treatments then. The authors suggested potential benefits. However, it's critical to note, as the source does, this report faced criticism methodological limits of a retrospective series, some ethical questions, as often happens with early reports on novel therapies.
Right, a strong signal needing more investigation, but not definitive proof. What about higher quality studies like sham-controlled RCTs for long COVID?
At the time the source was written, at least 2 were completed or underway. A Swedish group proposed an 80-case study and published an interim safety analysis after the first 20 patients.
What did that interim safety analysis show?
Blinding was maintained. The cohort had very low quality of life scores and physical performance at entry, as expected. Interestingly, they reported a relatively high rate of respiratory adverse events, 60% a cohort, mainly cough and chest pain discomfort.
High rate of respiratory issues even in the recovery phase.
It was noted, though the link to HBO2 versus underlying post-viral issues wasn't fully clear in that interim report. The source also mentions an Israeli group that reported results from their RCT involving 73 long COVID patients.
And this one was sham-controlled.
Yes, 40 daily sessions. Active group got HBO2, 100% O2, 2 ATA, 90-minute. Sham group got air at very low pressure, 1.03 ATA, on the same schedule. Blinding was reported as successful.
Crucial for subjective outcomes like fatigue or cognition. What were the main results?
They used a composite score for neurocognitive function. They found the overall score increased in both groups baseline to post-intervention. HBO2 group, 98.3 to 104.1. Sham group, 98.9 to 101.3.
Both improved, maybe placebo effect or just being in a study.
Possible, hence the sham control. However, they reported the mean improvement in neurocognitive score was statistically greater following HBO2. Average improvement was 5.8 points in HBO2 versus 2.4 points in sham. This difference was statistically significant, p0.04, using ANOVA.
So while both improved, the amount of neurocognitive improvement was significantly larger with active HBO2.
That was the primary finding. The authors concluded HBO2 can improve symptoms in long COVID patients, specifically highlighting neurocognitive gains.
Looking ahead, what's the potential role for HBO2 in post-viral syndromes more broadly?
The source suggests that once the specific effect in post-viral syndromes is better understood, HBO2 might find a place. Though candidates for post-COVID specifically might decrease as the pandemic recedes. By extension, if long COVID shares mechanisms with other conditions like chronic fatigue syndrome, HBO2 might also have efficacy there.
Potentially broader application if the underlying pathology is similar. Let's do a mega recap for the entire COVID section.
Okay, acute COVID, strong physiological rationale, hypoxia, inflammation, clotting, vascular damage, early promising data, observational biomarkers, suggested benefits, oxygenation, maybe reduced ventilation risk. But definitive RCTs for hard outcomes proved challenging during the evolving pandemic, making it hard to quantify clinical benefit despite encouraging signals.
And long COVID. Common, diverse symptoms, unclear mechanism, inflammation, clotting, hypoxia proposed. Initial case series showed striking positive results, fatigue, cognition, though methodologically limited. More rigorous sham-controlled RCTs show statistically significant improvement in neurocognitive function with HBO2 versus sham, though one safety analysis noted respiratory adverse events.
Yes. Overall source summary for COVID. HBO2's role is supported by preliminary data. Trials support use for acute refractory hypoxia, but evidence on full effects mechanisms limited. Need more well-designed studies. Experience relevant for future respiratory viruses. For long COVID, emerging evidence points to potential benefit, brain fog, fatigue, warranting more research. Optimal patient selection, timing, dose still need defining for both acute and post-acute.
Moving on now to acute acoustic trauma. Very specific hearing injury.
It is affecting the inner ear's delicate structures. HBO2 is effective for hypoxia, and hypoxia is extremely bad for the inner ear, especially the cochlea, the hearing organ. Acute acoustic trauma, sudden loud noise, can acutely reduce cochlear blood flow. That leads directly to inner ear hypoxia. Also, the cochlea's microcirculation, tiny blood vessels, can be disrupted, causing localized ischemia.
So, loud noise damages tiny cochlear blood vessels, starving hearing cells of oxygen.
That's the key link. The source also notes older individuals, maybe with age-related thinning of the cochlear vascularis, a key vascular structure, might be more susceptible to damage from the same noise level.
Does clinical evidence support HBO2 helping this inner ear damage?
HBO2 has been shown effective for sudden sensorineural hearing loss from various causes. For acoustic trauma, the proposed mechanism is relieving that cochlear hypoxia. The source cites multiple references supporting this, showing improved hearing outcomes in some studies.
Was there a systematic review looking specifically at acoustic trauma?
Yes, a recent one included in the sources. It looked at 3 retrospective series, 2010-2015, covering 116 patients. All 3 series reported hearing improvements in most individuals treated. However, the evidence quality was rated as low, typical for case series.
Low quality, but consistent findings of improvement across series. Encouraging signal, but not definitive. Any studies on treatment timing or strategies?
Yes, a retrospective review from the Czech Republic looked at 108 individuals. It strongly showed prompt medical treatment, especially steroids, meant much better hearing improvement. 96% improve if steroids started within 24 hours versus 53% it started 7 days later. So early intervention is key generally.
Timing for standard care like steroids is critical. Where did HBO2 fit in that Czech study?
Importantly, HBO2 wasn't used first line there. It was used strategically as a rescue method, offered to ears not showing sufficient improvement after a week of initial medical treatment, presumably including steroids. They tracked outcomes for these refractory ears. They found these ears showed improvements in pure tone thresholds in a remarkable 77% of cases after getting HBO2 as rescue therapy.
So even if initial standard therapy didn't fully work, adding HBO2 after a week salvaged significant hearing improvement in most.
Exactly. The authors concluded HBO2 proved a useful rescue strategy after 1 week in patients whose hearing hadn't recovered sufficiently initially.
What's the overall conclusion in the source material about HBO2 for acute acoustic trauma?
The source concludes these results, especially the rescue effectiveness, provide some encouragement for using HBO2 in acoustic trauma. But they strongly emphasize the need for more prospective data from high-quality clinical trials to definitively evaluate the impact and define HBO2's precise role, optimal timing, patient selection, maybe confirming that rescue role.
Mega recap for acute acoustic trauma.
Acute acoustic trauma. Rationale is relieving cochlear hypoxia from noise damage. Supporting evidence includes case series reviews, consistent improvement, low-quality evidence, and a key retrospective study showing HBO2 as a very useful rescue strategy, 77% improvement in ears failing initial therapy. While encouraging, especially for rescue, the field needs more high-quality prospective trials to solidify evidence and define HBO2's optimal role.
Let's move on to Raynaud's phenomenon and those challenging ulcers, particularly with systemic sclerosis. Also involves compromised blood flow, but different cause than frostbite.
Yes, rationale is again addressing compromised blood supply and hypoxia, but the cause is underlying connective tissue disease affecting small vessels. HBO2 relieves ischemia and promotes angiogenesis, new blood vessel growth. This makes its use physiologically reasonable in severe Raynaud's, and especially for those chronic non-healing ulcers due to the severely compromised circulation typical of these conditions.
Is this a new idea or is there history here?
Interestingly, the first reported use dates way back to 1967. 6 patients with scleroderma, a form of systemic sclerosis, got 2028 HBO2 treatments at 2 ATA.
And the outcomes in that very early study.
2 patients had complete ulcer healing. The rest improved overall, and improvement lasted several months for most. This was later corroborated by Marcus et al., reporting success in 2 scleroderma patients who healed ulcers after 30 treatments at 2.4 ATA.
So, not new. Some historical support. Tell us more about systemic sclerosis itself.
Systemic sclerosis, or scleroderma, is a relatively rare autoimmune rheumatic disease, maybe 1 to 5 cases per 10,000 people, characterized by excessive collagen causing hardening fibrosis in skin and organs. But a critical part is also significant damage to small blood vessels everywhere. This microvascular damage is severe in extremities, leading to chronic, painful digital ulcers, figure stows, that are notoriously hard to heal due to that compromised local blood supply.
Those ulcers sound debilitating and resistant due to the underlying vascular issue. What are the usual treatments?
Standard medical treatments aim to improve blood flow. Calcium channel blockers, endothelin receptor antagonists like bosentan, other vasodilators. These work for many, but a significant subset of patients still have persistent, non-healing, painful ulcers despite optimal medical management.
And it's for that subset with refractory ulcers that HBO2 is considered.
Precisely. The source highlights several studies. An initial one by Dowling et al. Treated 6 patients. The 4 with painful ulcers all got pain relief and healed their ulcers.
Pain relief and healing in chronic painful ulcers is huge for these patients.
Addresses both symptom and tissue damage. 2 more recent case series support this. Marcus et al. Treated 2 patients with intractable ulcers who failed other methods, both healed with HBO2.
Again, success in the toughest cases.
Correct. Another series by Marasoglu et treated 6 patients. 3 digital, 3 leg ulcers. 4 had complete healing, 2 had near complete healing.
Consistent findings across multiple small series spanning decades, showing high rates of healing even in severe refractory ulcers.
Yes, the pattern is consistent, though evidence is mainly case report series due to disease rarity. The source also includes a compelling case report by Poirier et al. Patient with severe systemic sclerosis, history of previous amputations due to ulcers, failed standard preventive meds, calcium channel blockers, endothelin receptor antagonists. Despite this severe history, she successfully healed her ulcer with HBO2.
A patient with actual amputations and failed prevention healed a new ulcer with HBO2. That really emphasizes the potential value in severe end-stage situations.
Powerfully underscores the impact. Now, given systemic sclerosis is rare, the source makes a practical point about future evidence.
Which is?
It states it's not reasonable to expect there will ever be a randomized controlled trial of HBO2 for these ulcers. The number of patients with severe refractory ulcers needing this is just too small and spread out. Therefore, the existing case series and reports are likely to remain the best evidence available for this specific application.
An important reality check on research limits in rare diseases. Don't hold your breath for a phase 3 trial.
Exactly. And based on available evidence, even without large RCTs, the source concludes, using HBO2 for these ulcers is reasonable for those patients who are not healing using medications. Furthermore, for the few patients who are candidates, severe chronic refractory ulcers receiving HBO2 can make a substantial difference in their lives, relieving pain and promoting healing otherwise unlikely.
Mega recap for Raynaud's and systemic sclerosis ulcers.
Raynaud's systemic sclerosis ulcers. Rationale is addressing ischemia-promoting angiogenesis in compromised microcirculation. Consistent findings from case report series dating back decades show healing of refractory ulcers, even after standard treatments fail or amputations occur. Due to rarity, case series likely remain highest evidence level. HBO2 considered reasonable and potentially substantially impactful for severe non-healing ulcers in this group when standard meds are exhausted.
Next up, diabetes mellitus, but specifically looking beyond diabetic foot ulcers, which is already established for HBO2.
That's right. Using HBO2 for complicated diabetic foot ulcers, DFUs, is well established, backed by RCTs and large studies. But there's long-standing interest in whether HBO2 might offer broader benefits to diabetic patients beyond just foot wounds.
And this interest comes partly from looking at the direct metabolic effects of HBO2 itself.
Precisely. Studies consistently show blood glucose levels tend to fall during HBO2 exposure in diabetics. Furthermore, good evidence suggests a course of HBO2 can lead to reductions in hemoglobin A1C, HbA1c, that long-term glucose control measure and significantly increase insulin sensitivity.
Increased insulin sensitivity is key in diabetes management. How might HBO2 do that?
The exact mechanism isn't fully worked out, but researchers showed increased insulin sensitivity specifically with hyperoxia, high oxygen, not just pressurized air. So it seems to be the oxygen. Animal data suggests one hypothesis. It might stimulate an increase in adiponectin.
That hormone from fat tissue.
Right. Adiponectin is thought to protect against insulin resistance and atherosclerosis, both major diabetes complications. So HBO2 might improve glucose metabolism by influencing this specific hormone.
Interesting hypothesis. Now, connect these metabolic effects back to broader diabetes pathology. Poor control leads to damage.
Yes, poorly controlled diabetes, hyperglycemia, causes chronic low-grade inflammation and widespread endothelial dysfunction, damage to blood vessel linings, especially in microvasculature, partly via reactive oxygen species and glycosylation.
And this microvascular damage causes many long-term complications.
Exactly. Damage to tiny vessels leads to microvascular complications, causing end-organ effects, diabetic retinopathy, vision loss, diabetic nephropathy, kidney damage failure, diabetic polyneuropathy, nerve damage.
So if HBO2 improves glucose control, insulin sensitivity, and is anti-inflammatory, it's plausible it could help prevent or treat these microvascular complications.
That's precisely the hypothesis in the source. It's conceivable HBO2 could help by improving glucose control via insulin sensitivity and by mitigating the chronic inflammation driving microvascular damage. Its own anti-inflammatory effect might be useful here.
Let's look at evidence for diabetic complications beyond DFUs, starting with diabetic kidney disease, DKD.
Fife et al. Reported on using HBO2 in patients with both renal failure and complicated DFUs. While likely treating the wounds, they saw a significant impact on kidney function. A remarkable 76% of the 835 patients showed improved renal function after their HBO2 course.
76% improvement in renal function in over 800 patients already in renal failure. That's a huge number in percentage.
A notable observation from a large series suggesting potential benefit, though not a trial specifically designed for this. However, there was a randomized study by Cardenas Ureña specifically on DKD.
What did that study find?
Patients with stage 3 or 4 DKD were randomized to 20 sessions of HBO2 or an air control. Outcomes measured kidney function indicators. The study showed significantly decreased proteinuria, excess protein in urine, marker of kidney damage, and improved glomerular filtration rate, GFR, kidney filtering ability, compared to controls.
So, a small randomized study showing improvement in objective markers of kidney damage and function, higher quality evidence.
It is. Furthermore, Sedlacek et al. Used data from the International Multi-Center Registry on Diabetics after HBO2 for various reasons. This registry data showed no increases in creatinine or proteinuria, markers of worsening function, and actually observed a trend toward improved renal function overall.
Multiple lines of evidence, large series, small RCT, registry data all seem to point towards a potential positive effect on diabetic kidney function.
That seems to be the emerging picture. There's also intriguing research at the molecular level.
Tell me about that metabolomics study.
Harrison et al.
Yeah.
Used metabolomics, studying chemical fingerprints of cellular processes. They analyzed urine from 17 patients getting HBO2 for DFUs. Standard course, 30 treatments, 2.4 ATA, 90 minutes.
Analyzing metabolites to see what's happening cellularly.
Right. They looked at changes before and after HBO2. They identified a suite of changes.
What did these changes suggest?
Biomarkers linked to renal injury, oxidant stress, and mitochondrial dysfunction were significantly reduced in patients getting HBO2. Furthermore, it suggested activation of molecular chaperones like heat shock proteins, HSPs, and heme oxygenase 1 proteins involved in cellular protection repair might play a role in reducing oxidative damage. These protective proteins are known to be influenced by HBO2.
So, molecularly, HBO2 seems to reduce kidney damage distress markers and potentially activate cellular protection repair in diabetics.
These molecular findings provide biological support for the clinical observations of improved renal function. There's also clinical data specifically on the glycemic control benefits.
Which study shows that short-term glycemic effect?
Irwan et al. Published clinical data from a non-randomized study of 30 DFU patients, compared two groups: standard treatment, insulin, IV antibiotics, versus standard treatment plus a short course of HBO2, 2.4 ATA, 90 minutes daily for just 10 days.
Just 10 days of HBO2 added outcomes after that short time.
Measured HbA1c start and after 10 days. Both groups got insulin, so some drop expected, but the reduction was significantly more with HBO2, standard group. The HbA1c stayed 9.7%. HBO2 group, the HbA1c dropped dramatically from 9.7% to 7.1% in just 10 days. P 0.001.
A drop from 9.7% to 7.1% in average blood sugar over only 10 days. That's incredibly rapid and clinically significant.
It is. Strong clinical evidence for metabolic effects even from a short course. The study also noted leukocyte counts, inflammation marker, trended lower with HBO2, 8,800 versus 11,000 YOL, P 0.18, not significant. Authors concluded HBO2 could assist in rapidly reducing glycemic and inflammatory levels, suggesting short courses might be useful to kickstart control. But this needs testing in a larger powered study.
That HbA1c data point is particularly compelling. Anything else mentioned regarding diabetes?
Yes, briefly. A separate, intriguing small RCT exploring HBO2 in a novel context, combined with autologous intrapancreatic stem cell transplant for diabetes.
Stem cell transplant for diabetes, how does HBO2 fit in?
In this small RCT, patients getting stem cell transplant into the pancreatic artery got either transplant alone or transplant, plus 10 HBO2 sessions, 2.5 ATA, 90 minutes. The combined group showed improved HbA1c, glucose, C-peptide levels, marker of own insulin production, and needed less external insulin compared to transplant alone.
Fascinating. Proposed mechanism for HBO2 enhancing the stem cells.
Authors hypothesize HBO2 somehow activates the injected stem cells, stimulating growth function of new insulin-producing islet cells.
HBO2 as a catalyst for the stem cells.
That's the hypothesis. But the source is clear. This intriguing finding needs to be replicated before the usefulness can be confirmed. Very preliminary, but potentially groundbreaking if validated.
Let's do a mega recap for diabetes mellitus beyond DFUs.
Summarizing diabetes beyond DFUs. Long-standing interest. Evidence points to metabolic effects. Lower glucose during treatment, lower HbA1c, increased insulin sensitivity, maybe via adiponectin. Physiologically, these plus anti-inflammatory effects suggest potential to prevent and treat microvascular complications like DKD. Evidence for DKD includes improved renal function in large series, decreased proteinuria, improved GFR in small RCT, registry trends, positive metabolomics findings, reduced injury markers, activated protection. Clinical data shows dramatic short-term HbA1c reduction with HbO2 in DFU patients, supporting metabolic benefits. Intriguing preliminary data suggests HbO2 might enhance pancreatic stem cell transplants. Source concludes strong case exists for continued investigation and ultimately RCTs to define HbO2's place in preventing treating diabetic end organ dysfunction beyond wounds. Finally, let's tackle traumatic brain injury, TBI. Massive global health concern, significant long-term issues. It is indeed a major public health issue. Millions affected worldwide, yearly, civilian and military. A big challenge, especially for persistent symptoms after even mild injuries, is the lack of a single, agreed-upon, effective standard of care for long-term treatment.
What are the numbers like, especially for mild TBI?
Globally, maybe 10 million TBI cases a year. U.S. alone, around 4 million a year. A huge proportion, 70–90%, are classified as mild TBI, MTBI. Notably includes about 25% of military service members from Iraq, Afghanistan, often from blast injuries.
So even mild TBI affects huge numbers, many with lingering disability. What are those persistent symptoms?
Many MTBI patients develop persistent disability. Chronic headaches, dizziness, fatigue, vertigo, behavioral difficulties, mood changes, confusion, impaired balance, sleep changes. Very common are cognitive impairments, memory, attention, concentration deficits, executive function problems.
Clearly debilitating symptoms, and research is moving away from drugs for this.
Yes, these persistent symptoms drive lots of research because current approaches are limited. Focus is increasingly on non-pharmacologic rehab, as drugs often have side effects, sedation, cognitive dulling, that compound the disability. In this context, HbO2 emerged as an attractive potential option due to physiological effects relevant to brain recovery.
Why is HbO2 attractive for TBI? Proposed mechanisms.
Proposed mechanisms might vary by injury phase. Acute phase, right after. HbO2 elevates oxygen in blood and injured brain tissue. This increased oxygen provides vital energy for cellular function and neuroplasticity, the brain's ability to reorganize and form new connections.
Helping the brain get energy for initial survival and recovery.
Yes. Then, chronic phases, months, years post-injury. HbO2 hypothesized to work via several mechanisms for repair generation, improving cellular metabolism, reducing apoptosis, programmed cell death, alleviating oxidative stress, increasing neurotrophins.
Neurotrophins, protein supporting neuron health.
Exactly. Crucial for neuron survival, growth. Source suggests HbO2 might increase them by enhancing mitochondrial function in neurons, ultimately contributing to ongoing tissue repair and regeneration.
So chronic phase. Potentially reversing subtle damage, promoting healing, enhancing brain's repair machinery. Let's look at clinical evidence. Source points to the first high-quality RCT for HbO2 in MTBI, late 2012.
Yes, landmark study, 50 military service members, combat-related MTBI. RCT with sham control, 30 sessions over 8 weeks. Sham group tear at slight pressure, 1.3 ATA daily, 90 minutes. Active group, HbO2, 100% oxygen, 2.4 ATA, same schedule.
Careful sham control is critical here. Outcomes measured after treatment.
6 weeks post-treatment. Tailored post-concussion cognitive test, post-traumatic disorder checklist for PTSD symptoms common in this group.
And the primary finding of this first high-quality RCT?
Primary finding: no statistically significant differences in outcome scores between the HbO2 group and the sham group at 6 weeks. However, and this made a complex analysis of pre- versus post-trial, showed both groups had statistically significant improvement in scores. P is literal 0.001 compared to their own baseline.
Okay, no difference between groups, but both active and sham groups improved from baseline.
Correct. This sparks considerable debate. Was it truly negative for HbO2? Or did it highlight the problem of finding a truly inert sham for HbO2 trials? Maybe even slight pressure or trial context caused effects. Source refers to discussions by Mitchell and Bennett, 2014. For the full debate, interpretation isn't settled.
Complex results, ongoing discussion. What about studies after this initial one?
Source states many subsequent studies suggest HbO2 may indeed be beneficial for some individuals with MTBI who have persistent, subtle symptoms, may be missed initially. Potential benefit particularly noted for those with concurrent PTSD, common with TBI, especially military.
Specific study examples supporting potential benefit in subgroups or symptoms.
Outcomes from the brain injury and mechanism of action, BEMA study, are mentioned. BEMA found that by 13 weeks post-treatment, HbO2 improved post-concussive symptoms, PTSD, cognitive processing speed, sleep quality, balance function. However, key detail source notes these changes did not persist beyond 6 months in follow-up.
Benefit seen at 13 weeks, but faded by 6 months in BEMA. Suggests that benefits might be temporary or need ongoing intervention.
One interpretation. However, the source also presents other scientific evidence, including from RCTs, indicating a course of HbO2 for adverse sequelae after brain injury does improve outcome, shown even with lower pressures 1.5 ATA. Crucially, this evidence suggests outcomes appear better and more sustained when HbO2 is given concomitantly integrated with frequent specialized brain injury rehabilitation.
Makes sense. Support the brain with HbO2 while it's actively doing intensive rehab. Suggests it's part of a comprehensive approach, not standalone. Is it clear yet which TBI patients respond best?
Source notes selection criteria for which patients will improve is not defined precisely yet. Potential benefit seen in some, but identifying ideal responders needs more research.
Current evidence grade for HbO2 and TBI versus other treatments.
Source states clearly, Phase 2 clinical trials exist that support improvement in some. But results from Phase 3 efficacy trials, large, multi-centered definitive proof do not currently exist.
Promising Phase 2 for select groups, but no definitive Phase 3. But the source makes a strong claim comparing evidence levels.
It does. Asserts the level of evidence for HbO2 for persistent post-concussive syndrome is higher than other drug or other therapeutic intervention commonly used. Specifically, lists psychotherapy, cognitive behavioral therapies, citing multiple references.
Powerful claim. Suggests despite debates and lack of Phase 3, HbO2 evidence might currently be stronger than for many common non-drug interventions for persistent TBI symptoms. Is there a mechanistic link to other conditions HbO2 treats?
Yes, a compelling parallel to carbon monoxide, CO poisoning, an established indication for HbO2 for neuro effects. Advanced brain imaging, MRI, DTI, fMRI, SPECT/CITIGA, shows neuronal injury patterns in TBI correspond to abnormalities and symptoms also seen in CO poisoning brain injury patterns.
So brain damage and symptoms can look similar in TBI and CO poisoning.
Precisely. And crucially, there's established experience with successful reduction in brain injury from CO poisoning using HbO2. This known benefit strongly suggests a shared mechanism by which HbO2 could benefit all forms of brain injury, including TBI.
Proposed shared mechanism.
Key effects of HbO2: ameliorating brain inflammation, improving blood flow, promoting tissue repair via induced neuroplasticity and angiogenesis, new blood vessel growth. These effects align with the needs of a brain recovering from trauma.
Strong biological rationale, linking established CO benefit to potential TBI benefit via shared pathways. Given this complex picture, debated trials promising later findings, rehab link, evidence claims, mechanistic links, what's the author's cautious stance, and clinical recommendations now?
Authors take a measured, cautious stance. State explicitly, until more definitive info available, they do not support a blanket approval of HbO2 for post-brain injury sequelae, not advocating it as standard treatment for everyone yet.
Not recommended for widespread use yet, but a role in specific circumstances.
Yes. Clarify clinicians may make individualized decisions about using HbO2, considering specifics, but they strongly outline the ideal scenario if HbO2 is considered.
What does that ideal scenario look like?
First, full informed consent. Patient must know they may or may not improve, emphasize uncertainty. Second, ideally, potential enrollment in a clinical trial or registry trial to collect prospective data. Third, and perhaps most critical based on evidence, treatment ideally done at specialized centers experienced with complex brain injury and offering high-quality concomitant integrated brain injury rehabilitation alongside HbO2.
Individualized decisions, transparency research link, and crucially, delivered within comprehensive care, including specialized rehab, aligns with that promising multimodal approach.
It does. A pragmatic clinical approach based on current evidence, cautious on widespread use, acknowledges potential benefit, emphasizes maximizing success and contributing knowledge if used.
Let's wrap this section with a mega recap for traumatic brain injury.
Summarizing TBI, especially mild TBI with persistent symptoms. Major issue, lacks definitive standard care. HbO2, attractive due to mechanisms supporting neuroplasticity, acute, and repair regeneration. Chronic. Evidence complex. Initial high-quality RCT debated. Sham control issue, both groups improved. Subsequent studies suggest potential benefit with PTSD. The one study, BMO, showed temporary effects. Evidence indicates outcomes better with integrated rehab, multimodal approach. Phase 2 trials support improvement in some. No Phase 3 efficacy data yet. Source claims evidence level higher than for many other common non-drug therapies. Strong mechanistic link via similar injury patterns to CO poisoning. Established HbO2 benefit via inflammation, blood flow, neuroplasticity, and angiogenesis. Author's stance. Cautious, no blanket approval yet. Individual decisions possible. Ideal scenario. Full informed consent, uncertainty, trial registry enrollment, specialized center offering integrated rehab.
Stepping back from the specifics, what are the overall conclusions from the source material about this whole field of emerging indications for HBO2?
The source circles back to HBO2's fundamental actions. While best known for relieving hypoxia by boosting oxygen, studies increasingly show other crucial biological effects.
Beyond just delivering oxygen.
Exactly, not just passive delivery. HBO2 actively reduces inflammation, improves tolerance to oxidative stress, and stimulates hypoxia-inducible factors, HIFs, proteins involved in cellular responses to low oxygen, paradoxically stimulated even in high oxygen.
So broader effects. Inflammation, stress response, signaling pathways.
Precisely. And the source notes this very diversity of possible mechanisms impacting oxygenation, inflammation, oxidative stress tolerance, growth repair pathways, likely explains why HBO2 has been tried and shows promise in such a remarkably diverse set of seemingly unrelated conditions. Back at that long list and the registry figure we discussed.
Offers a biological framework for why one treatment might hit conditions from IBD to TBI to vascular calcification. They might share underlying processes HBO2 influences via these diverse mechanisms.
That's the key insight. And the final call to action from the source is clear. Further investigations are needed, well-designed, rigorous studies to fully understand how HBO2 works in these various indications, to find the optimal ways to use it, pressure, duration, frequency, total treatment, and ultimately define its precise role and patient selection criteria.
So we've taken a comprehensive deep dive into this dynamic, challenging world of emerging indications for hyperbaric oxygen therapy. We've seen many potential applications being explored across a wide spectrum, but the evidence is often still building, from promising case series and observational data to smaller, sometimes debated RCTs facing unique challenges.
We've explored the physiological rationales, how HBO2's diverse effects might help in refractory IBD, calciphylaxis wounds, frostbite amputation risk, acute and long COVID recovery, acoustic trauma hearing loss, systemic sclerosis ulcers, certain diabetic complications, and persistent PBI symptoms.
And acknowledge data limitations, rarity of conditions, logistical hurdles for big trials, but also seen that for some rare conditions, case series might be the best we get, and HBO2 evidence, even if not phase 3, sometimes compares favorably to evidence for existing standard therapies.
It's a field with ongoing scientific curiosity, clinical innovation, and that slow, careful process of gathering data to solidify the role of a therapy with potentially broad biological effects.
Absolutely. And that brings us to a final thought for you to ponder. Considering HBO2's wide range of effects, not just oxygen, but influencing inflammation, oxidative stress, regeneration factors, where else might this unique profile prove beneficial? Think about other conditions characterized by similar underlying issues: chronic inflammation, microvascular dysfunction, challenging tissue repair where the body's own mechanisms seem stuck. The journey to understanding HBO2's full potential is clearly, well, far from over.